says.
Is that better? I'm glad you were observed. So anyway, thank you for the introduction. So Chris Blythe, as I said, I'm a paediatrician across the road and work for both the university and for Telethon Kids in the hospital. And I'm going to build on some of the work that Chris has shown me that you've been exposed to, which is really around, I suppose, the role of development and regulation to really focus in on vaccine safety, approval and surveillance, and I suppose try to use some real world examples, including some local real world examples of why I think that's an important step, but also some of the challenges of doing that. But before I go on, I'd like to acknowledge we're on Noongar Wujak Wujak, pay my respects to elders past, present and emerging, and particularly highlight the important role that vaccination has in protecting Aboriginal families from the harms of vaccine preventable diseases. And as Chris also mentioned, a lot of the work I'm going to present here is my own opinions after nearly a decade working with the Australian Technical Group on Immunisation. So I was part of that group from 2012 right up to 2021, including some of the more challenging last couple of years. And so I'm going to talk on vaccine safety. Why is it important? Look at vaccine development and particularly the approval. Why is it so long and how was it abridged during COVID? Look at post-marketing surveillance. I suppose it's really highlight why bother, but also show you how it's done in Western Australia, done in Australia, and then use a COVID example of what I believe is the importance of communicating risks and benefits and some other challenges. Now, we haven't always had such a focus on vaccine safety. Here's Jenna inoculating James Thrips, who was his gardener's son, with cowpox from the lady on the left-hand side, who's the milkmaid, who had cowpox lesions on her hands, but had a beautiful complexion because milkmaids didn't get smallpox because they got inoculated with cowpox through their work. So Jenna wanted to prove that theory, so he inoculated James Thrips with cowpox in this diagram, and he developed a pox scar, and then he exposed him to smallpox a month later and clearly demonstrated that cowpox immunity protects against smallpox. And so really the issue about vaccination and the history of vaccination was born. You can trick the immune system into past exposure and by doing so protect. Now I know Chris has highlighted in one of his examples, and I'm going to touch on that because it really is sort of one of the big early vaccine safety scares. So this is the US in the 1930s, 40s and 50s where polio epidemics were rife. So particularly in that post-war period, there was global outbreaks of paralytic polio, which had been through populations for genera prior to that. And importantly, this was spread by fecal-oral transmission, and a small proportion of those exposed to the first 3 enteroviruses, which are the polio viruses, developed paralysis. A proportion of those would recover or partially recover, and a portion were left with lifelong injury as a result of their polio, and death did occur, particularly with those who had complete paralysis. And really through this paralysis, the iron lung movement and the intensive care unit was born. But the picture on the right hand side is actually James Salk, and I know Chris has highlighted particularly in his lecture the rivalry between Sabin, who was his senior and his tutor, to Salk, who was the junior at this stage, as they were both racing to develop a polio vaccine by quite different mechanism. Sabin was using a way to try and reduce pathogenicity, so a live attenuated virus through serial passage through multiple cycles of cell culture to try and reduce the pathogenicity, and Salk was using a different method. He was inactivating polio by adding formaldehyde to the polio virus to disrupt the virus so that what was left was actually the components which the immune system will recognise. And ultimately, Salk won. And in the US, amid rising polio numbers, you can see actually what happens with the polio numbers between the mid and the late 1950s. A rapid disappearance was because of the rollout of polio vaccines to children in the US. Now, Salk won, and 5 manufacturers were given the license to develop the Salk vaccine, which was really slopping formaldehyde into your vat of polio viruses to inactivate them. This is Anne Gottstenker, and for all purposes she was a polio sufferer, but different to most polio sufferers, she got hers from her vaccine. So the Cutter incident, that it became known, was where hundreds of thousands of doses of polio vaccines were poorly inactivated. In fact, they had live virus in them, and large numbers of children were affected by the polio from their polio vaccine. And the Cutter incident really was one of those landmark cases that drove development of regulation. So Anne Gottstenker actually took the US government to court. She was infected at the age of 5, and through this legal process really highlighted the importance of regulation, and it was clearly a landmark case. So 5 companies were given the license, and one, the Cutter company, unfortunately didn't adequately inactivate it. So to put it in summary, mass polio vaccination was occurring in the 1950s, and nearly 400,000 doses of the Cutter vaccine was delivered, and probably about a third of those were not inactivated. And it resulted in 260 cases of polio, 160 children left permanently paralysed, and 10 died. And so, although regulators were present prior to this, it was really a clear demonstration of the need for vaccines to come under their lens. And so, the regulation of vaccines, like drugs, has evolved from there. And so this is a list of the regulators. Most developed countries have their own vaccine regulator, someone who basically is tasked by government to make sure the safety of vaccines, make sure that as a prescriber of vaccines, such as myself, I have confidence that what is in the vial is in the vial, and importantly, there's nothing else in the vial that's going to cause harm. So we have the Therapeutic Goods Administration in Australia. In the US, they have the Food and Drug Administration. In the UK, they have another regulator. And although there's lots of European regulators there, there's also the EMA, which is the collective European regulator. Now, these regulators share information. Not all of them are doing individual reviews, but importantly, all of them have individual responsibilities to the countries they're established and in. So the TGA is responsible to the Australian government and the Australian people to make sure that what we use is safe. So let me jump from the 1950s to 2010. So, CSL FluVax. So in 2007, we had a severe flu season in Western Australia and a number of children died of flu. And as a result of that, based on what was happening in other countries, particularly the US and Canada at that stage, the WA Department of Health elected to do a preschool flu vaccine program. Very similar to other countries we're doing at this time. So an injectable vaccine to try and prevent children from getting flu. And as Chris highlighted, a lot of this early work was part of my PhD. And we vaccinated in 2008 and 2009, and close to 50% of children in this state at that age were given a flu vaccine at that period of time. And we launched the 2010 program up here with fanfare to truly try and make sure that we reached the group that were under-vaccinated. So as I said, we've got about 50% vaccine uptake, which is actually really good for a seasonal vaccine, and particularly in the second year of the program in 2010, we really started pushing hard. But 7 weeks in, the wheels were falling off. A number of people had noted, particularly those working in emergency departments or in general practice, a large number of children presenting within 12 to 24 hours of the influenza vaccine with high temperatures, and a small proportion of those, about 1 in 200, were having febrile convulsions. And so the program was stopped. This puts it in timeline. So the trivalent vaccine was launched in March 2010, and we had increasing reports, particularly through Princess Margaret Hospital, which is the hospital that I worked in, and we notified the TGA, and 9 days later the program was suspended. And to put numbers in reality, febrile convulsions occur. Children get febrile convulsions, but it was really a real uptick in both febrile convulsions, which is in blue, but also these other febrile reactions. This is ED data from 9 metropolitan emergency departments showing a real change, a much earlier onset of change than we'd expected. And when you drill down to the numbers, this is what it looks like. So within 72 hours of an influenza vaccine, children presenting with febrile convulsions in 2008 were 1 in these 9 emergency departments. None in 2009. We had 38 children in 2010 presenting with 72 hours of their influenza vaccine. So at that time point, we clearly had a standout. Something was different this year compared to earlier years. So the odds ratio of having a febrile convulsion in 2010 was 44 times. And we started doing some parental surveys. And this is what it showed. There was 2 vaccines being distributed in Western Australia at that stage. FluVax or FluVax Junior, which is produced by one manufacturer, CSL, and Influvac, which is produced by another manufacturer, Sanofi, at that stage. And we saw a stark difference between the two. About 17%, given the Sanofi product, had a parental reported fever, and there was a challenge about parental report, but clearly there was a stark difference with over 50% of the FluVax recipients saying they had fever. But actually more stark than that, 2% vomiting versus 17% vomiting, less than 1% of rigors versus 15% rigors. We saw an absolutely stark difference in the safety profile, even through these parental reports. And this was occurring in the days and weeks after suspension of the program. And clearly this got both national and international profile, and a lot of people were very critical about Western Australia having an influenza vaccine program at that stage. So there was a virus in the system about not only the vaccine, but also our ability to monitor vaccine safety. And this girl is a girl called Saba Button, who was left with an irreversible brain injury and still attends PCH to this day, and has a severe neurological outcome as a result of her CSL FluVax. So it's a bit of a reminder of the importance of vaccine safety and how cautious we need to be. Now, what was the underlying cause? Well, there's lots of investigations, and the company did their investigations, we did our own investigations, and in short, the clinical picture of the reaction was very similar to some of the very early flu vaccines in the 1970s, whole cell flu vaccines, where it really was flu in a blender to make a flu vaccine, what you do is you take the hemagglutinin protein, which is the surface protein that you develop antibody to, you refine it down, and we use that. So actually, the vaccine that you get and I get has 4 purified hemagglutinins. That's as opposed to early flu vaccines, which is really flu in a blender. Whiz it all up and you get a whole stack of other stuff. You get RNA, you get lipids, you get other proteins as well. And the reactions that we saw were very similar to those early reactions. And so both the company and ourselves found that actually the splitting of the virus to make the vaccine was inadequate in 2010. Now this was actually a vaccine we'd used for many years, and in times past it wasn't inadequate. So in other words, when you actually have a strain change, sometimes you need to have more of the splitting agent, which is a deoxycholate acid for influenza, and the dose you require may vary by the virus you're trying to split. In 2010, it was inadequately split. And CSL had a unique product of splitting compared to the other companies that used a different product. But as a result of this, there was really national and state inquiries into vaccine safety. And so the national review was a Horvath review, and it called for the creation of the Committee of the Safety Vaccines, which is a subcommittee of the TGA, which really focuses on do we have sufficient information about the safety, and it's tasked with reviewing national signals. TGA was instructed had to have better processes, and there was a call for active surveillance following the introduction of new vaccines. When we introduce a new vaccines, we need to work hard to make sure that we don't see any of these early safety signals. So we don't wait for 7 weeks like we did in Western Australia in 2010. We're detecting at week 1. The Stokes Review called for the West Australian Vaccine Safety Advisory Committee to be established, and I sit on that committee and have ever since. It's asked for the establishment of the vaccine safety surveillance system in Western Australia. It called for clinics where adverse events could be followed up, and we run those clinics at PCH and across here at the moment, and also called for active surveillance. But the other important piece from those of them, you needed clear communication. Who was doing what? If a signal was detected in a jurisdiction, it would flow up to the Commonwealth, and importantly, the other way around. Now, not surprisingly, parents voted with their feet. So this is the first 2 years of the flu vaccine program in Western Australia. This is the number of doses distributed per week in 2008 and 2009, where we got close to 50% of the population vaccinated, and you saw what happened in 2012 and 2013. And actually, we struggled for a number of years until we had a number of high-profile deaths again in 2018 and 17 to get flu vaccine up again. So it's stay long enough in vaccine safety, you see some of these cycles. I'm now going to give another example, which is a different example and not a West Australian example of a vaccine safety signal and how it's investigated. So I'm going to jump to Japan now and look at HPV vaccine. So the human papillomavirus vaccine, protecting at that stage against 2 or 4, but now we have 9 different types of human papillomavirus. And in Australia, we've had programs for girls from 2007 and boys, I think, from 2011 to try and reduce HPV infection. Get it at high school. 3 doses initially. We're actually now down to a one dose schedule in boys and girls, and we've seen a dramatic reduction in HPV events, so genital warts firstly, but actually we're now starting to see a drop-off in cervical changes and cervical cancer. So we're actually seeing what we expected we'd see 10 years ago is actually by preventing early HPV infection, we would reduce the impact of cervical cancer in women and penile and anal cancers in men. Japan introduced the vaccine, made it available in 2009. It was funded by some programs in 2010 for girls 12 to 16, and it was listed on the national program in 2013. And at that time, schools and authorities were really pushing hard following the listing to try and get vaccine uptake, which at that time was about 50% to close to 100%. But following the reports in the media, and I'll talk about those, about 10 weeks into the program of side effects, the recommendation by the vaccine safety group was not to push school or community programs. And with this, uptake plummeted from what was close to 50% to less than 10%. The first report actually came in March 2013, and Japanese people love newspapers. And so newspapers are really important in Japan as far as the shedding of information. And the Asahi Shimbun, I would say that wrong, is a very well-respected newspaper. And they reported on a girl who'd suffered a severe adverse event that was thought to be attributed to HPV. And it particularly was associated with movement disorders, chronic pain, and memory disturbances. And other papers picked up other stories from families and young girls who'd similar reported stories, and the story propagated from there. Now, after 9 months of investigation, the ministry was sufficiently convinced that it was psychosomatic. It wasn't related to an ingredient in the vaccine. And they put this information out there, but the challenge was the media cycle had started. And some of these plots give you an idea about the media cycle. So if you look at this plot, grey in this plot is actually vaccine uptake. So close to 50% in the years 2011 through to 2013, a signal, and then real dwindling vaccine uptake from that time point. Things such as yellow, prior to that, was really about the cost of HPV vaccine and how they were trying to get it for free, the screening recommendations, and all of the positive messages about HPV vaccine disappeared. Blue is adverse effects from HPV vaccine. Same time, dramatic increase in media reports, and this is media reports over that period of time, increase, and people damaged as a result of the HPV vaccine. And thirdly, the reports of those who'd suffered harm as a result of HPV vaccine and their reports. And so in this sort of environment, it's very hard to sustain positive vaccine messages, and not surprisingly, you see a dramatic difference. So these are women born between 94 and 99. So remember, at this stage now, they're really in 2010 to 2012 receiving a vaccine. Many got a vaccine. Here, these are women born in 2000. So in that period of time, post-2013. There's a couple of things. Clearly the vaccination rate dramatically dropped and HPV infections increased. And so this generation of Japanese women are clearly at great risk of harm associated with HPV, which was vaccine preventable. Now, the reason I give you an example, there is absolutely no evidence that this was HPV associated. This has been reviewed at a Japanese level, at a national level, at an international level, and the safety signal hasn't been replicated. We've been running HPV programs with the same vaccine over that period of time and have not seen the same safety signal. So safety signals sometimes are real and we need to respond appropriately. Sometimes they're not real and we need cautious and appropriate and early communication to the public about what we're seeing so that we don't lose vaccine confidence. Any safety signal will impact on community confidence. We know that, but actually how we build and maintain that is a really important step. So let me jump now to vaccine development and approval. Many of the vaccines I've talked about, so HPV vaccine was 15 years in the evolution. And that's from preclinical studies through to animal studies, and then phase 1, phase 2, phase 3 studies, then seeking approval here through a regulator, production, and then rollout. The pandemic changed that, and changed it for a couple of things. This slide doesn't highlight that actually the number of pandemic vaccines we used actually had been used before. So that AstraZeneca vaccine was very similar to a vaccine we used in the Ebola epidemic in 2014 and 2015. So we had the technology there, and importantly, it was designed specifically where you could pull out the active element and put in a new active element into the Chaddock vaccine that makes it to be able to be repurposed for a new pandemic. mRNA vaccines were in place in 2018 and 2019 in clinical trials for flu. We knew that mRNA vaccines, because of their speed of production and the ability to modify, were an attractive option going forward. And they'd actually been used in animal vaccines before that. So a lot of this technology was there. But also, in 2020, we really changed the way of doing things. The preclinical work was done there, but actually phase 1, phase 2, phase 3 all occurred in overlapping ways. In other words, the patients who enrolled in phase 1 actually were included in the phase 3 study, but we needed sufficient numbers at that stage to move to the next level. The monitoring of these people was ongoing, both from an efficacy and a safety perspective, but we moved to the phase 2 and we moved to phase 3, which means we went from February, identifying the genome in 2020, up until the release of the phase 3 data, which occurred in late November, early December 2020. So from the public's perspective, we had the fastest vaccine production in history, and it was, from 11 months, but importantly, some work had been done beforehand. And so, regulators gave emergency registration to COVID vaccines in December. Now in Australia, we didn't actually give approval until February. And there's a backstory there. In 2009, when we were rolling out the H1N1 pandemic vaccine in Australia, there was incredible hesitancy because of the emergency use provision. It had been rushed. And so we took longer to approve COVID vaccines in Australia by pushing them through the normal pathway, the normal series of checks that the TGA does, which does take longer, about 6 weeks longer than the emergency setting. And we did that because actually we didn't have a lot of COVID around at that time, and we believed at that stage that that would instill public confidence, as opposed to the approval occurred in the US and in Europe, which was awash with COVID at that time, clearly having significant impacts on hospitals, communities, and morbidity and mortality, where their desire to rush forward, as I would have made the same decision at the time if I was in their shoes, was high. So let's talk about the approval process in Australia. So this is normal. Normally, a vaccine needs to be registered by the TGA before it starts the process. And most often, a pharmaceutical company will come through to the TGA to say, I've got a new product. I've got a new product that I believe is efficacious, effective, safe, and is implementable, and probably has a role on the national program. Now that company needs to submit to the TGA the evidence dossier that proves that. And that goes through a number of steps. The Committee on Vaccine looks specifically at the safety. A TARGI, which I chaired, was the one that really looks at the evidence, looking at efficacy. Does it work? And does it have a role in the program? Why would you come forward with the vaccine if there's no disease in the country? So does it have a role, and how do you implement it? And once you've done that, you move to the second step. And the PBAC is the group that works out whether it's cost effective. And to get a vaccine on the national program, it needs to be cost effective. So in other words, the national program is where it's available on every GP fridge, every pharmacy fridge for you, as opposed to something that you might think is a good idea, but actually doesn't need at a population level. So for example, many of our travel vaccines are not on the national program because there's no point in rolling out a vaccine for yellow fever in Australia. We don't have any yellow fever in Australia. It doesn't have a role in the NIP. It's really important and it's available to those who need it, but it's not on the national program. And so to go on the national program, it needs to be demonstrated that it's cost effective. In other words, the cost of the vaccine actually is cost neutral or cost saving to the Australian healthcare system because it prevents disease. And then The government negotiates price with the vaccine manufacturer. It approves the vaccine. It's listed on a legal document called the determination, and then the Commonwealth procures it and starts a program. And the cycle goes back. ATAGI writes the handbook about how you give it, when you give it, who you give it to, and it's listed on our schedule. And if you look up immunisation schedule, you'll see the West Australian schedule, which is virtually the same as every other state's schedule, which is those set vaccines given to both children, adolescents and adults. This is a really robust system. It's a robust system that allows us to deliver many vaccines at a reasonable price, because that negotiation, pushing hard with companies to make sure they give it a decent price, means that actually it saves you as taxpayers money. The downside of this, it's probably about 18 to 24 months from top to tail. And so it's not very pandemic ready. It's not fit for purpose in a pandemic because of that speed at which it's done, particularly waiting for a company to come forward to us. Well, that's at the company's whim, and we're a small country. So if you've got an international market for lots of vaccines, are they going to bring it to the Australian market? Probably not. Are they going to bring it to the Australian market when we'll try to screw them down in price? Probably not. Also, it's slow as far as the series of steps that you need to before you can get studying vaccines in arms. So we did need to make some tweaks to the approval process prior to our COVID vaccines. So the initiation of the process is normally a sponsor application, but actually we set up a body that I sat on, which was actually reaching out to companies to say, we want your vaccine. And we want a range of vaccines, and we were doing this into 2020 ahead of us knowing whether any of them would work. And we're reaching out to companies to try and get a range of different vaccines, working in different ways, manufactured in different countries, because we did not have confidence at that stage that the vaccine that we were looking at was going to work. The regulatory decision is still exactly the same, TGA with ACV. The purchasing decisions, instead of being Australian government, was really advice from SciTech. The clinical information was exactly the same. ATAGI drove that, and importantly, the implementation of the program, instead of it being purely Commonwealth, was really a combination between Commonwealth and states, with the Commonwealth leading that. I'm going to jump you back to a slide. So post-marketing surveillance is a network that occurs in states and territories to try and identify safety signals. And clearly both the Horvath review and the Stokes review in Western Australia pushed for us to have a better safety signal, a safety program, so that events of 2010, which took 7 weeks to recognise we had a problem with our flu vaccine, would not occur. And so I'm going to talk about that now in the last little while and use some COVID examples. Post-marketing surveillance relies on two things. Passive surveillance. So passive surveillance is whether a provider or you and yourself, if you're a vaccine recipient who've had an adverse event, report to state or national-based organisations. So you say, I've got a problem and this is what the problem looks like. Active surveillance is whether you use processes to reach out to vaccine recipients at set time periods, and they used to be email surveys, we now do them text-based surveys, to reach out to say, actually, what did you feel? Did you get a sore arm? Did you get any side effects? Did you need to go to hospital? So you try and get early detection of signals. Both of those have their limitations. We want to welcome both passive and active reports, but you do need to marry them with a causality assessment. Because as I'll show you, particularly during COVID rollout, you get a huge amount of, I've got a sore arm, or I felt sick for a day. And they're the sort of side effects that actually we kind of expect. And importantly, that's okay. But you need that to make sure you capture the severe stuff. So post-marketing marketing surveillance in Australia has two elements. The passive bit is through the TGA, so this is the TGA's portal. You can jump in, you can report directly to the TGA, but many states, including our own, run our own vaccine safety programs. So this is WAVS, the Western Australian Vaccine Safety Surveillance Program, which is basically got a database called SafeVac that we share with Victoria, and you are encouraged to log your vaccine adverse event. Providers actually have to by law, it's part of the Health Act, that if you have someone presenting to you with adverse events, you're meant to log this. And so this is the portal where you do that. And importantly, we share this with a TGA. And we do this because actually it means that you can have a phone line there. If someone needs to talk to somebody, it's easy to do this. If you do it into the TGA, it's a little bit of a black box. Now, active surveillance started post-2010. And these are the data I've already showed you. So this is with flu vaccine WA. These were the parental surveys showing fever of 55%, rigors at 15%, vomiting at 17%. And we actually repeated these surveys in WA in 2011 and 12, and then in multiple states in 2013. We reached out to parents of flu vaccine recipients and said, what symptoms did you get? And we got remarkably consistent results. So low rates of fever, rigors and vomiting, very reassuring safety signal. And we did this really to highlight to parents and providers we weren't seeing a signal. Nothing here to see. Flu vaccines in small children did okay. Now this is Alan Lieb. He developed a system called SmartVax that are really operated through Western Australian GPs that has now gone nationally to do it from the electronic GP software. So many of you who go to specific GPs may get a text message from SmartVax at day 3 or day 8 after your vaccines. How'd you go? It's usually 2 questions. Did you have a side effect? Yes or no. Did you need to see someone? Yes or no. And if you say yes to you got a side effect, you're asked what that looks like. And if you say yes, you needed to see someone, you're asked did you go to a GP or to hospital. And all of these programs now are being rolled into AusVac Safety. So AusVac Safety is a national initiative that involves all states, and so it means that we can produce data like this. So the 2023 flu vaccine, we've done 200,000 surveys at this stage, and we know that 17% reported at least one adverse event, which is remarkably consistent, but most importantly, 0.3% went to see someone about it. 0.3 thought their adverse events were severe enough they went to see their immunisation nurse, their pharmacist again, their GP, or had to go to a hospital. And so by tracking these numbers, we can get incredibly early reassurance we don't have a 2010. And we actually know within about 7 to 10 days of the program occurring that we don't have a 2010 now with the volume of surveys that are occurring. And Western Australia still leads the way, bucket loads from Western Australia and New South Wales, but importantly, we've got incredible broad reach across the country, including in specific populations and including specific high-risk populations like pregnant women. So let me jump into post-marketing surveillance. When we think about post-marketing surveillance, I think about 4 buckets. We need the active and passive surveillance piece. We need to be reaching out or encouraging safety signal reporting. You don't know what you don't see. We need a causality assessment. We need a group of trained clinicians who says, that sore arm is what you expect. That is not what you expect. That's something that's more severe. And importantly, not only is that important from understanding, but patients want it too. They want to know, was this important? 2, how does it change what I do next time? What do I do about it? So those clinics, both at PCH and QE2, continue to operate at the moment. And we see children each week who've had a reported adverse event, some of which is real, some of which is not. Now you need good governance and oversight processes. And importantly, you then need to have appropriate communication and policy development around this space so that you can respond. And so in my last 5 minutes, let me take you through some COVID examples. And this is where communicating risks and benefits became really tricky. So, take you back, February 2021, Pfizer vaccine rolled out in Australia, and 3 weeks later, AstraZeneca vaccine rolled out in Australia. We had little COVID circulating in Australia at that time. Remember that 2020 Victorian outbreak had largely come down and most places were COVID-free. There was hotel quarantine. And in that March 2021 time, reports started coming through, particularly from Europe, about blood clots related to the AstraZeneca vaccine. They were largely occurring in young women, but importantly, AstraZeneca vaccine was being rolled out in Europe for healthcare workers. And so, healthcare workers by nature are more likely to be young and more likely to be female, and so we were trying to work out at that stage, that signal, whether that was related to the population receiving the vaccine or not. At that early stage, we were also trying to work out whether it was related to the vaccine, because young women, they might be on the oral contraceptive pill, other things, sometimes get clots. And different countries approached it very differently. The safety signal was there. Germany paused and then allowed the vaccine for use for older people. The UK, which was awash with COVID at that time, did not pause, and it continued saying that anyone over the age of 30 should get the vaccine. Younger people should probably have an alternative. And Denmark paused and didn't start. And importantly, these are the data we were trying to interpret at this stage, which were relatively small, and we started to see a signal between what you expected and what you didn't expect between 49 and 50. We started seeing that actually these number of cases was higher in that group. And so we paused AstraZeneca use for under 50s. We advised government through a target that we did not believe that under 50-year-olds should receive an AstraZeneca vaccine at that time. Now I'm going to take you through the words because these were spent 5 days to write. We recommended that Pfizer was preferred over AstraZeneca in adults over the age of 50. You say, well, that's soft language. But importantly, we knew that we, at any time, could be in the middle of a COVID epidemic. And we did know at that stage that actually the rate of events of this was low and the rates of impact of COVID was high. And so we gave that advice to government. Unfortunately, that was massacred a bit by our Prime Minister at that stage, who really set up the, if you're young, you get Pfizer, if you're old, you get AstraZeneca. And then you started getting newspapers like this. So this is a West Australian. This is one of the ladies who developed TTS, so had a clot from her AstraZeneca vaccine. She was 51. She's been left with a hemiplegia. So she's had a significant impact from her vaccine. And this is really hard to try and take control back of the narrative with data when this is in the front page. And so we reviewed the data, and this is what we said. So we continued to say that actually we didn't believe young people should be getting the AstraZeneca vaccine based on the signal we're seeing, but importantly, really highlighting that actually this is in the presence of limited disease and things could change at a moment. And we would need to change our approach. And we needed to change our approach over a long period of time because we were vaccinating really high-risk people through this period of time, high risk for disease and exposure, healthcare workers, quarantine workers, and then we started with Aboriginal people and we started with those who had underlying conditions. But it's this period of time we were really getting into the young adult population. So what happened with vaccine safety signals? Well, this is data from the West Australian Vaccine Safety Surveillance Program that had been running for a decade. And we used to get signals every week, someone reporting an adverse event, but clearly in March we saw a rapid increase. So we got over 1,000 reports per month of vaccine safety signals. Now we need to interpret this with caution. One, because at this time there'd been no major vaccine program. Two, we were asking people to report their adverse events. We'd actually switched on SmartVax for the whole state. So everyone was getting a text message at day 3 and day 8, and that was coming directly into this. But we did this intentionally because we wanted to know. we wanted to know how people were feeling post their vaccine so we could detect the safety signal. But I can tell you, trying to manage this flow of reports and having an expert review on all of these was a very challenging time. And this puts it into perspective as well. So this is 2017 to 2020, where we used to get 64 to 80 reports a year. We went to 8,000 reports. 8,000 reports in young adults. I'm a paediatrician. I don't usually do that many young adults as far as that sort of stuff. But we clearly had to surge to make sure we were covering on this. And importantly, a huge amount of self-reports, which we wanted, but was challenging. And the early reports were with AstraZeneca vaccine, particularly during this time when there was increasing international signals about clots. And then over time, as the amount of Pfizer vaccine increased, we got increasing reports about Pfizer vaccine, and the rates are there as well. So this is Spikevax, which is the Moderna vaccine. This is here is Comirnaty, which is the Pfizer vaccine, and this one here with that early spike in March when a lot of this information was coming out was AstraZeneca. And this is what they're telling us. So headache was really common. Headache is pretty common after a vaccine, particularly a reactogenic vaccine, but unfortunately headache is one of the symptoms of TTS as well. So trying to tease out what is a normal headache from a not so normal headache is really challenging. I put chest pain is because clearly the Pfizer vaccine is associated with pericarditis and myocarditis. But actually, every person who has angina started reporting their angina to us as well. So trying to tease out, this is an old person who has stable angina that every time they walk a little bit more gets a little bit of chest pain, and it's occurring post their vaccine from actually this is a safety signal, is really hard. But important. And it means that we can then calculate these numbers that inform the risk and the benefit. So over the course of 2021, we were able to determine that your risk of TTS was about 1 in 50,000 doses. So 2 per 100,000. It was rare. Really terrible for those who sustained it, but actually TTS was a rare problem. Myocarditis and pericarditis, slightly more. So second dose Pfizer, 100,000. So we're looking at about 1 in 15,000 individuals developed myocarditis from their Pfizer vaccine. Again, terrible for the person who sustained it, but also still relatively uncommon. And the other challenging bit about that is we then need to interpret that in light of what's the risk of severe disease from COVID. And the risk of severe from COVID is dependent on how much COVID there is. You don't get any severe disease from COVID if there's no COVID. But once there is COVID, it's problematic. And so we started producing these plots in 2021 in the middle of the Delta epidemic, particularly as New South Wales were kicking off, that showed, actually, you know what, your risk of harm if you're a 40 to 49-year-old probably was greater with TTS if there was little COVID around than the risk of COVID. But actually in these groups, even with very little COVID around, you're much more likely to be harmed from the COVID than you were TTS. You start looking at it when you get a bucket load of COVID around, and this is what it's looking like in New South Wales in the outbreak of 2021, and we were then trying to say, actually, 59-year-olds, go and get a vaccine, because your risk of dying is far much greater from this than it is from your clot. And so ATAGI was constantly trying to change the narrative. So it seems like a lifetime ago, but it's only 2 years ago that Delta hit western suburbs of Sydney. Remember the taxi driver who got pillared from, highly criticised about spreading from an airline crew? This was back then. And so we had a population that were under-vaccinated at that stage, particularly a young adult population that had deep scepticism about healthcare and about vaccines, and it took off. And so we had to, again, change the narrative. We had to say that actually, you know what? If you're old, go and get it. Don't wait. If you're young, really have a strong think about, can you access a Pfizer vaccine? If you can't, you should go and get an AstraZeneca vaccine. But actually, if you're a 60-year-old in Tasmania or Western Australia at that stage, probably your risks were low because we didn't have disease. So, let me summarise. So, following phase 3 trials, regulation, approval and implementation are critical steps, and they do need to be managed. Things that don't effortlessly go from the end of a phase 3 trial to a program. I've given you some examples of when it's gone wrong. Whether there has been a safety signal or there's been a pseudo signal that's not necessarily been managed well, and it has a real impact. And if we're going to prevent tragedy, harm from vaccines or harm from vaccine preventable diseases, we need to manage this well. We need active and passive surveillance to ensure signal detection, and we continue and should continue to encourage reporting, because it's the only way we have to keep our finger on the pulse. And we do need to have mechanisms, or we've got mechanisms that we had to set up pre-COVID, but have really been taxed during COVID and now well in place to assess causality. Did this vaccine result in this harm? And we need to be cautious about community confidence. It's easy to shake, it's easy to lose, and at the moment we've got scepticism about vaccines post our COVID vaccine rollout that is going to take years to restore. And so I believe rapid, open, transparent communication to not only community but providers and government needs to continue, because we will have another pandemic. We will have another vaccine rollout that we need to do, and if we don't do it well, unfortunately we're going to continue to see deaths from vaccine preventable diseases. And with that I'll stop and happy to take your questions.
So with the, it's obviously a bit more rapid for the COVID vaccine to be approved.
Yep.
Do you think that's going to become the new framework, or is it going to sort of revert back to the traditional?
I don't think anyone wants it to become the new normal. Now,